Hello and welcome to ComplyPlus Presents. I'm joined in this new year with Dr. Richard Dune, and this is our first episode of 2026. So welcome back, Richard.
Oh, thanks, Royce. Good to be back.
Yeah, it's been a while since we've been sat here together.
Yeah. I think it was November
November
last year.
2025. Yeah. So it's been a long time, and obviously one thing that might be worth informing the listeners of, because our frequency of these podcasts is changing now. So obviously we're moving to one episode per month rather than a weekly edition.
Yeah.
There will be some special editions along the way when we see fit, or there's a topic that we particularly want to maybe discuss. But in general, we're going to try and stick to the one per month. And Richard, I know you wanted to go into a bit of detail as to why we're doing that so the audience understand the change.
So the weekly format worked very well.
Yes.
We didn't actually think we'd be able to keep up with it.
Yes.
Whether there'd be enough to talk about. But I think it did a lot better than we expected. And we had a lot of guests coming in.
Yeah.
And there's so much to talk about. There's so much stuff going on, the changes in health and social care, how the sector is responding, how we are responding. But what we realized was that we were not really going deep enough into some of the issues that we were discussing. It was good to spend the whole year doing a weekly podcast. It was fantastic.
It was a great routine, wasn't it?
Exactly. We also did 3 webinars where we took some of the key issues we discussed in the podcast to webinars. And those 3 webinars did very well. What we realized was we needed to balance it. So we'll stick to one main episode per month. Then we'll do some special editions in between as and when we get an exciting guest or something comes up that needs to be addressed straight away, we'll do it. We're also going to disseminate more in a structured way from the podcast to the webinars, what we do with ComplyPlus platform, the blogs that we write, the other things that we're doing. So there's so much more that we can do by delving deeper into individual subjects. So that's really the logic behind moving to one a month.
One a month, yeah.
Yeah.
Like you say, I think it gives us a good structure, and particularly with the webinars last year, they were really good. Obviously, webinars, because they're live, the engagement there with the audience, even us, we learn things from the people that are attending to tweak things, whether it's products that we're building, whether it's services we want to offer, whether it's understanding pain points a bit more. So, the webinars have been great, but also the feedback on this podcast has also been really, really helpful as well.
Yeah.
So we've had a bit of time to think about the topic to start 2026 with, and we feel it's a critical topic that we didn't really touch on as much last year as a subject matter, whereas this year we feel it's a really key topic, and we were really excited to talk about this today. So it's one of the most persistent and high-risk areas in health and care services, and that's medicines management. So, Richard, you've worked closely with organisations navigating enforcement action, special measures, recovery. Why is medicines management such a high-risk area, and why is it so important that people like us talk about it on this platform?
Yeah. So, talking from experience, working in frontline services, NHS, in the private sector, even in prisons, it's one of the high-risk areas because medicines have the potential to harm people. Of course, if they're used correctly, they're handled correctly, they're stored correctly, the whole point is they will make people feel better.
Feel better, yeah.
So it's the danger that comes with the territory, but also our risk appetite in a way. If you take risks, actually with medicines, they can harm or even kill people. So whether it's care homes, NHS trusts, again and again, when you look at CQC inspections, we looked at like a 12-month period, organizations that were rated inadequate and some that were rated as needing improvement. The majority of the issues are related to medicines management. So some of it is to do with safe handling and administration of medicines, but that's only a small portion of medicines management. Medicines management looks at the whole infrastructure. So you may be administering them safely, handling them safely, but actually the other areas, documentation, record keeping, policies and procedures may be lacking. So we actually looked at what's happening with organizations that are inadequate or needing improvement. And the errors, what we realize is that errors don't happen in isolation. So we're looking at failures around leadership to sort of say, if you're not well-led organization, then you're going to not, you're going to struggle to give people safe treatment.
Yeah. So that
with
link again, going back to governance, leadership.
Exactly.
It's the same sort of themes, isn't it?
Yes. Training,
Yeah.
organizational controls.
Yeah.
So you can get your training right, but your organizational controls are not there. So you're failing.
You still get the error at
Exactly.
the end, yeah.
Yeah, so it's one of those areas that quickly exposes how an organization really functions. No matter what they say on paper, it tells you what's happening underneath by just assessing that whole infrastructure.
Yeah.
Yeah.
And like you say, they are a big part of what's going on in these settings, aren't they? Because ultimately people are there to try and, as you say, make people feel better. So yeah, it's very, very important.
Yeah.
I suppose one of the key questions for the people that are likely to be listening to this would be, why does medicines management matter so much when it comes to CQC inspections?
Yes, because it sits at the crossroads of what regulators care about, right? Because it's about giving people safe treatment. It's about safeguarding people, because sometimes actually you're administering medicines or you're helping people to take medicines. So competencies, staff attitudes, training, systems within the organization. So it's a very broad area that tells you about safety, tells you about competencies, governance, leadership, safeguarding, everything there. So it's not just a clinical task, because I've seen people just treating it as a task. Oh, who's going to do the ward round? Not the medicines round, rather the drug round. For care workers, they go and do an online course, and they shadow somebody for 2-3 days, and then they're free to go and start helping people with medicines, right? And so it's not simply about whether the tablet is given the right time or the right dose. It's bigger than that. It's an indicator of actually organizational activity and how it links with the wider governance and control of the service that they're giving to people, the safety of that service, the effectiveness of that service as well. Yeah.
So you've, in part, I think you've answered this next follow-up question, but inspectors aren't just looking at the medicines round itself.
No, they're not. They're asking actually, what does this tell us about how the organization actually works?
Yes.
Right. They're not trying to catch you out, but they're testing actually your systems, stressing your systems, which you should be doing yourself actually in your own audits, by the way, because when you register actually with CQC, you're telling them that you're going to manage risks. You're going to have systems in place.
Yes.
Register manager is going to do this. We're going to hire people to do this. They're just merely checking that you're doing the things that you said you're going to do.
You said when you said,
Right?
yeah,
They're not trying to catch anyone out. So if medicines are not being handled safely, if I'm an inspector, I'm going to reasonably assume that other systems may also be weak.
Yeah.
Yeah. And I'm also going to be thinking, oh, what is their training like, actually? What is their record keeping like? What is their supervision? What about incident reporting and visibility of leadership? That's one of the biggest failures as well. I know we'll talk about it separately, Regulation 17, where there's just no visibility of leadership. They're there to sign things off and make sure things are paid, maybe make sure the books are fine, but actually from service delivery itself, they're missing.
There's nothing.
Right? So medicines management becomes a kind of safe practice flag in a way. It's one of those areas that tell you very quickly as an inspector how things really are.
Yeah. And then it can open up other cracks.
Yeah.
And so on. So, like you say, medicines is almost an early warning sign.
Oh, yes, certainly.
For deeper investigation in a way.
Definitely. You have to treat it as something that everyone in the organization should care about.
Yes.
Not just the clinical team. For example, if you go to nursing homes, actually, the nursing homes that we have worked with, they just leave it to the nurses.
Yeah.
Sometimes the care home manager has no clinical training. Not that they need clinical training, but actually they have to take an interest in what their nurses are doing.
Or at least understand.
Yes, you can just defer to the nurses. You have to take responsibility as the registered manager or the owner of the business. Same as in the NHS, it's not just clinical teams. There's health and safety elements. There's the HR elements. The financial element. There's so many things that you need to consider. So it's a whole system issue, not just a clinical issue.
Yeah.
right? Which is sometimes is taken as. So staff need to be trained and be competent. You know, you look at regulation 18, 19, actually to meet that. You have to make sure that you've done it properly and it's evidenced properly as well. Documentation also needs to be accurate and up to date from the perspective of clinical oversight, but also even from a clinical governance perspective as well. The usefulness of that documentation and being kept up to date. And then risk assessments as well. So you're identifying risks. And so you start with hazard identification, then you do your risk assessments, and then escalation processes as well, including accident reporting, incident reporting is really crucial when you think about that. And where incidents happen, we're not blaming people. Obviously, if there are people issues, we deal with them. But actually, we're looking at the system to say, why did we fail here? And learning, organizational learning.
That's really important, isn't it?
With intent, actually, to sort of say, look, what did we get wrong here? Because you find actually that some organizations then refer nurses very quickly to NMC because they're looking at blame. That's the wrong way to look at it.
Yeah.
You're looking at safety of the service users first and foremost, and your responsibilities as an organization actually, also the well-being of staff. Because sometimes actually it's not the problem of the staff; it's actually the system itself that's making the staff not do as well.
Yeah.
In that sense,
It's hindering performance.
yeah. So leaders actually, like I said earlier about visibility, you don't have to be there on every shift, but actually you need systems that tell you how you're doing as far as medicine safety. Because when things break down, it's actually ultimately your responsibility as a leader.
Yeah.
Yeah.
Excellent. So if we move on to, for example, when CQC identify medicine's failures, what are the likely causes of those failures ultimately?
Yeah. So I did touch on risk management.
Yes, risk management. We
Yeah.
highlighted quite a lot in the last
It's,
segment.
it's one of the biggest areas actually that if you are managing your risks in a systematic way, you're doing your audits regularly, you're monitoring your systems. I mean, you look at the NHS Trust and large private healthcare providers, they do have the clinical governance framework, which they're required to have by law. And it does catch some of these things. But you and I know that we've worked with large organizations that have failed on medicines management.
This particular area, yeah.
In this particular area. So it's not foolproof itself, but having a formalized clinical governance structure does help. Then if you're in the care sector, obviously you don't have the infrastructure that large organizations have or large NHS trusts or even smaller NHS trusts have. But you still need to think about your care governance to say, look, what am I required to do actually to deliver, at the very least, a good service, right? But the thing is, if you're just aiming to get a good service, that's such a low bar.
Yeah, it's the wrong mindset completely, isn't it? Yeah.
You want to deliver exceptional services, and you start actually by understanding your risks within the organization. And also how you're going to mitigate those risks and how you're going to escalate them all the way to reporting. Then fragmentation as well, or unreliable documentation. So documentation and record keeping when it comes to medicines management is absolutely crucial.
Yeah, it's critical.
Because if I finish my late shift and somebody's taking over a night shift, they should be able to just look at the records and see what has happened, what medications this person has. Is there anything new that has been prescribed? It should be really clear. If they've taken PRN medications, or those are medications that people take as and when required, it should be documented clearly as well so that we avoid underdosing, we avoid overdosing. So documentation is absolutely crucial. Then also staff sometimes are unsure or unsupported because, if, depending on the service that you're running, you can get some new medications prescribed and people have never given that medication. Maybe they're unsure. Of course, you can always refer to the BNF, which is a formulary where all these medications are listed. But actually, it's good to have it as good practice to say, whenever you get new medicines, to improve confidence of people, you don't have to send them to a full training course. You can do a quick team meeting, where you can do a lunch and learn, where somebody explains what's going on, why this medication is needed, what to look out for, how does it interact with everything, and make sure it's documented properly and sign off people that they're competent to do what they're supposed to be doing. Then it goes to assurance of competencies as well. Many organizations are not showing that people are competent. They will go and do a course, but a course doesn't make you competent straight
Course
away.
doesn't equal competence. Yeah, we've had this discussion with
Yeah.
so many providers. Yeah,
Yes, if you look at nurses, they spend 3 years for nursing training in the UK. And during the 3 years, they're doing pharmacology, they're doing anatomy and physiology, they're doing a lot of things, and they're writing exams, they're going to placements, but still, when they qualify, they don't start giving medication straight away. They have to be supervised. I think it used to be 6 months, but it depends on the organizational system, 3 to 6 months. Then you sign them off, and then they can start giving medications independently. And sometimes, actually, certain medications, they're restricted until they've done additional training. But we're seeing failures in the care sector where people are being rushed to go to work and they're not ready, and the competencies are not signed. The records may be there, but they're not signed. Sometimes there's no records at all of training. Sometimes there's no evidence of safe practice at all. And I mean, these are coming straight from CQC reports. We looked at real CQC reports.
They're not like dark secrets. They're in the public domain. Yeah.
They're known. If you talk to any inspector or if you talk to any commissioner, these are things that keep them awake at night. When we do talk to them, they worry about these things. Right? That's why we talk about them now. That's why we include them as well in our training and our guidance and all that. And the final thing, obviously, is leadership blind spots. I think we can even do a whole podcast on how to show leadership when it comes to medicines management on its own, right? So there are a lot of blind spots where they're unaware of the problems happening in their shop, basically. And they wait almost for inspectors to highlight them. You should know as a leader, you should have systems actually to check these things and monitor these things. So inspectors see safe medicines practices. They don't see it as a one-off mistake. It's hardly ever a one-off mistake. It's linked with so many other things, underlying organizational weaknesses that have not been explored. And sometimes they don't even know that those weaknesses exist.
Yeah.
Yeah.
I think that's a really important distinction, isn't it? It might be worth just elaborating on that.
Yeah, look, the problem is people focus on errors and blame.
Yes, blame culture.
Blame culture.
Yeah.
Rather than looking at, hang on, have I given people systems?
Yeah. What is our system? Sometimes actually putting yourself in the system
Yes.
is a good way of knowing how good or
Exactly.
bad the system is. Yeah.
Exactly. I remember last year we went to the patient safety conference. One of the chief nurses, actually, she's a fantastic chief nurse. She was wearing trainers on stage. Everyone else is dressed in these expensive suits. She's just wearing trainers. And she says, look, I dress like this even when I'm in the hospital. So that if I'm needed to go and help on the ward, I very quickly just change and go and work on the ward. I have to walk around so much. I can't walk around in high heels. And everybody laughed. And I started thinking, but that's really good, actually.
Yeah, she's practical.
She's always prepared to jump in. And that's true leadership, actually, when you think about it. To say visibility matters so that you are not actually, when errors happen, actually, you almost know, actually, that, look, if I don't deal with this area, there's going to be an error. So it forces you to deal with things if they're visible and also if you're visible, right? So retraining staff, rewriting policies, updating procedure, it's hardly ever enough. You need to understand the cause of the causes. Deep understanding, actually. And even when you do root cause analysis, people do it as a form of investigation so that they can blame someone. That's not the point of a root cause analysis. You're doing it actually to look at systemic issues and be able to address them properly. So if you look at inspectors, they're thinking about bigger questions. They're not looking at one error. They're saying, look, why did the system allow this to happen in the first place?
Error to happen, yeah.
Yeah? And, assurance mechanisms are weak or they're not embedded in the workflows. Then medicines management practices expose them very quickly. You can't hide. It will just happen because people are not connecting training with policies and procedures. Maybe they're under pressure with other things. Maybe medicines administration time is not protected. It's going to show very quickly.
Yeah. Yeah. The inspector wouldn't have to be there long to spot it. So, like you say, it's not just about harm that's already happened. It's about that risk of harm as well.
Exactly. So CQC as a regulator, they're fundamentally risk-based as a regulator, right? And how we handle medicines actually tells them whether people are protected now and whether whether leaders are confident that they'll be protected tomorrow. Because if a security inspector comes today, they'll see a different picture from what they'll see tomorrow,
Yes.
right?
Yeah.
I remember when I worked in the hospital, one of the things we did was some audits, like venous thromboembolisms, people that have DVTs, clots in the legs and clots in the lungs. And quite often they would know when we are coming in to do these audits. That was the culture.
Yeah.
Then we just changed. We just used to turn up.
Yeah.
Then organizations that used to get 96%, 98%, 100% on their audits started getting less than 50% because we're not giving them time to prepare.
Yeah.
We came in and did audits when they were
Least expected.
least expecting it.
Yeah.
And it told us exactly
True reflection.
how their systems are working underneath, right? So that's the key there, to say you're not trying to catch people out, but actually if leaders cannot demonstrate how medicines risks are identified, also how medicines risks are monitored and controlled on an ongoing basis, then Regulation 12, safe care and treatment, and Regulation 17, it's exposed straight away. There's poor governance, and you cannot be confident that people are going to be given treatment that is safe and care that is safe. Yeah.
So yeah, ultimately, medicines management becomes a proxy for governance.
Oh, yeah, certainly, because when you look at how much it features in inspection reports, sometimes it's just one or two lines, but it tells you that it's a bigger problem and it needs to be addressed at system level, right? And it's also one of the fastest ways for inspectors to see whether systems actually are fully embedded, policies and procedures are fully embedded into practice and how they are working.
Excellent, thank you. So I want to spin the conversation slightly now and look at common failures. Not just common failures, but with context. So what do they really indicate? Because we can all reel off common failures, or we can go and get that information on the first one or two pages on Google or AI or wherever. But actually understanding what they indicate, I think, will be really interesting for some of the listeners. So when you look across different settings, whether it be hospitals, care homes, domiciliary care services, ambulance services, for you, what patterns really stand out?
It's quite consistent, actually, which is quite shocking in a way. Like I said to you earlier, when you look at large organizations, they will have a clinical governance director.
Yes.
They'll have maybe chief nurse responsible for patient safety and quality. There's people responsible for safeguarding. They're well-resourced. But actually, even they are struggling. Some of them are struggling, actually, to prove that they're keeping patients safe, to prove that they're managing medicines properly. So regardless of the setting. So, of course, the way CQC inspect hospitals is going to be quite different now. Now they dish the single assessment framework now, which is the better way to go.
Yes.
But again, you find that the same problems keep arising in different ways.
Yeah.
Because sometimes, actually, if you have poor governance in a large organization, then you're just going to have problems at scale, isn't it?
Yeah.
Then in a small organization, some organizations actually, depending on the leadership, they actually have better controls than bigger organizations. So there's no one size fits all in a way, right? So you have to look at different organizations. But MAR charts, for example, the medicines records, they sometimes are not aligning with prescriptions. Right? If you compare then with the patient notes or service user notes, then there are some discrepancies there. Missed doses, delayed or double doses sometimes. That's a common feature in domiciliary care, particularly where you have care workers. Nursing homes, you still see challenges, but there are better systems because you've got nurses handling these issues and they've got better structures, better relationships with community pharmacies and GPs, and maybe even awareness as well of pharmacology does help in that sense, right? Then PRN medications, so these are the ones that people take as and when, if they're in pain, for example, or if their blood sugar is high or whatever the case, right? Then sometimes they're given without clear rationale. They start being given every time instead of as and when required.
Yeah.
Right? So there's no person-centered care. So sometimes there's no follow-up as well. Sometimes you have to check with the GP to say, they're getting more pain. Do we need to increase the dose or change the medications? So those conversations sometimes are not happening. Another area is weak oversight of controlled drugs. So controlled drugs like morphine, for example, It's a highly addictive drug.
Yes.
And it's those drugs. Some variations of them are sold on the streets, and they fetch a lot of money. Some organizations, actually, even NHS trusts, have had issues where they're not documented properly, and sometimes actually disappear completely. That's a different issue altogether, but actually that shows very poor structures.
Poor structure, yeah.
In that sense. And unsafe storage, missing temperature monitoring, because some drugs need to be handled at room temperature or in the fridge or whatever the case. Then if you don't handle them correctly, then that's a problem. And also expired drugs as well, still being used, still kept. That's a bigger problem. That's a big problem as well. Then staff administering medicines without any assessed competencies, right?
Which is a big issue.
Big issue, because you have so many issues that could happen there. So they're not rare or exceptional findings. Like I gave you, there's several examples from NHS trusts, from private hospitals, from care homes, domiciliary care. Even, like I said to you, I worked in prisons for nearly a year and a half. We used to find similar problems. It was a real challenge. So it's across different settings, and it's this information, you see it in the inspection reports over and over and over again. It's quite surprising that even if you go 3, 4, 5 years, it's the same problem that keeps recurring. It's absolutely baffling.
Yeah. I think, like you say, because of the area it is, like you were talking about, the controlled drugs. I wouldn't say hassle is probably the wrong word, but the things the systems needed around it, it only takes a few things not to be documented properly or people to understand the process, because it is such a crucial area, medicines, as we said. So I think the interesting thing you've said there is that they're not exceptional findings. Obviously, it doesn't necessarily say health and social care in the UK is completely unfit for purpose, but the fact that these issues, like you say, keep coming up, and the patterns even from the last sort of 3 to 5 years are still quite consistent even in today's day and age, I think is interesting. And I think the other interesting thing you said there was that these issues turn up whether the organisation is large or small. There's no there's no sort of size bias in a way to say that because it's an NHS trust, because it's a big private healthcare provider, their systems are much better than the smaller care providers. Yeah,
definitely. It doesn't matter what size of organization it is. Some organizations are multi-site. We worked with some multi-site organizations. They have fantastic services. They'll have the leaders on one site, then teams working in different areas. They've got fantastic systems. You almost expect multi-site organizations to fail more, but it depends on the leadership of the organization. Yeah. Everything comes down to the leadership.
Unique to that.
Governance.
Yeah.
Governance. And what changes is how visible the underlying problems are. Because even when we've done recovery work, we worked with a few organizations that were rated inadequate. A couple of them ended up getting outstanding in their next CQC inspection. But they worked hard. We spent, one organization, we spent nearly 2 months working with them, and working with people in cleaning, people in the kitchen, the nurses, the doctors, talking to the patients themselves. They turned everything around, and they got outstanding rating or good rating. And so it is possible. It is possible. The problem is people don't dig deep enough sometimes. You need outsiders sometimes to come and show you things that are so obvious. They're in front of you, but you're not seeing them because you're blinkered.
Yeah, you've been in the organisation
for far too long.
And outsider's perspective is important with these sort of issues.
Yeah.
So when inspectors see these kind of failures, I think you've already hinted at this already, but they're not just looking at the medicines process itself. It does trigger a deeper dive into other processes and things going on in the organisation.
Yeah, they don't exist on their own. Like I said, actually, if you are failing on Regulation 12, it may trigger a safeguarding concern.
Yes.
You're into Regulation 13. How are you going to get a good rating already? 2 regulations.
Those key regulations,
It shows poor leadership. So you're not well led. So already flouting Regulation 17. Go to your staff, Regulation 18, 19. All of a sudden, everything is falling apart. It's never an issue on its own. It's almost like a window to how the organization is working, despite what they say on paper.
They say on paper, yeah.
Right? So there are other wider failures that actually are associated with this. Audits sometimes are tick boxes, not designed properly, so they will never detect risks. So, and people do them just default, it's an autopilot, so there's no thinking involved at all. Even where they have electronic systems, not all electronic systems are created the same. Some of them actually are just merely transferring what you have on paper and putting into digital.
Yeah.
It doesn't make any
doesn't
sense.
actually
It doesn't change anything.
Change anything that's actually happening, yeah.
Yeah, and sometimes issues are reported and identified and reported repeatedly, but there's no improvement, there's no action in the escalation process. And also incidents recorded, but they're not analyzed. You need somebody to be actually responsible for accident reporting, incident reporting, and analyzing actually near misses as well, where they are seen. But near misses, in most cases, are not talked about at all.
No.
Right. And no clear escalation when something goes wrong, because people are worried sometimes as well about reporting because they worry about being blamed.
Being blamed again.
And sometimes people report because the culture is report so that we can blame this person blame that person.
X person,
right?
Y, yeah.
And evidence of learning not being shared. Maybe actually there is learning, but it's not disseminated to the relevant people.
Yeah.
And so they haven't learned anything. You may learn something as the manager or as the senior person on the shift. But if you don't tell everyone else in the handover, in the staff meetings, it's a wasted opportunity to learn.
But we've also seen with training where some people haven't turned up or, they've missed the training day, particularly when it's an in-person session or a face-to-face session. The chances of that session then being rescheduled for the benefit of those people that have missed the session is not going to happen.
There's no hope.
It's not going to happen. So then you sort of think, well, how are those people, are they actually up to date with their medicines management training? Have they missed some critical information, and how are they going to be able to get that critical information back? So I think it's a very key point. And
but going on that as well, Louis, the issue is that they're treating training as an event.
Yes.
So let's get everyone in the room. They do the training. We get certificates. Then we take our orders to say we've got the training.
And everyone's
But actually, if we missed one or two people, what are we going to do with that person? How are we going to cascade what we've learned? How are we going to maybe rebook them into a future session? How do we cover the gap? Because almost every time when we have done face-to-face training, there's always people missing.
Yeah, very rarely you get a full register of the intended people compared to actually who show up.
So it's around then contingencies for that to say, if you're just doing one big session a year over 2-3 days, then somebody's off sick or annual leave or they're pregnant. When they come back, it's almost like, look, they were not there. Then maybe they do e-learning, but actually that they've missed actually what you learned from the group, the discussions that we had.
Exactly, and quite often, if you have a good facilitator, we've all been on good training, we've all been on bad training sessions in our life, but if you have a good facilitator, particularly with this sort of subject, there's lots of conversations, there's lots of case studies, there's lots of things you can learn outside of just the theory side of medicines management and medicines administration. So again, that's where that building internal capacity comes in. I think we are going to touch on it later on, but building internal capacity, having champions in the organisation, so that if you are relying on external providers, then you don't need to necessarily say, oh, can we book another date in for this, or we can't find a time to bring you back in. You've actually got people in the business that...
so train the trainer model will help.
Exactly,
cascading training, they don't have to be expert trainers, but what they can do is bridge the gap.
They can bridge,
and minimize the risk. It can also be part of the supervision process. Like we said, lunch and learn to bring people up to speed. But again, it needs to be documented properly. You need good systems in place. And you need to actually connect the dots as well. The problem here is that people are not realizing that those two people, that's actually a risk point in itself.
Yeah, it's a huge risk, really. Yeah. So I suppose the stuff we're looking at there, the bigger picture stuff then comes in, doesn't it? You're sort of at the... Medicines is almost like the tip of the iceberg in a way.
Definitely. So again, if you can see the iceberg, great. But actually sometimes icebergs are hidden, aren't they?
Yeah, and you hit them and
you hit them,
and you worry about it.
Then you are dealing with a big problem. So you need to always have good quality assurance systems underneath. And even where you find weaknesses, actually acknowledge that and let everybody know that we found weaknesses and this is what we're going to do about it. The problem is we almost want to make our organization look very clean and sterile. No organization is perfect.
No.
If you're a learning organization, you're always going to be finding points actually of learning from whether failures or weaknesses, and that. So if you consistently apply these systems and embed them into day-to-day practice, then there's less chance of you hitting those icebergs. But at least you can see them from afar.
Yes.
Right?
Yeah. The key is to be able to see them from as far away as possible, really.
Exactly. So audits.
Yeah.
Learn. Every registered manager should know how to do audits. All their senior carers should know how to do audits. Every nurse should know how to do audit. Every GP. So at your level, people should know how to do it. And then as a manager, then I can then rely on those people. I can then depend on those people. So don't treat it as a tick box exercise, right? It needs to drive action, right? To learn and drive action. And incidents are logged, but no one joins the dots to see recurring themes. And we see this actually, like in CQC reports for care organizations. There are drugs that are quite fitly to work with, epilepsy drugs, blood thinners, even diabetes as well. They have to be given a certain time and you have to do certain tests and you have to monitor. Those monitor systems are not there. So it's about actually, as an organization, learning. And whenever you get a new patient or a new service user who's got a completely different pathway that they're following on a certain drug, learn about that.
Yeah.
Find out from the prescriber
Actually,
so that then everyone else can
some research
use it
yourself,
safely.
Yeah. So I suppose that's where the leadership element comes into it then, isn't it?
Yes, we're going to sound like a broken record to say, look, it's all about leadership.
Leadership, governance,
It's
leadership.
all about leadership. If you need a reliable line of sight as a leader. Those reports actually need to matter and they need to be visible as well to you and people that are actually doing the work as well. So, training has to be up to date, yes, but it's not enough to just have up to date training.
No.
Right? As we say it over and over again, policies are in place, yes, but actually, do people understand those
People actually
policies?
know where they are or what they mean, yeah.
Yes, are these policies and procedures connected to the training? Because there's no point actually just ticking a box every year to say we've done training, but we've not localized it to how we're working.
In
and
this setting,
also the audits have to be completed. So from an inspection perspective, actually, if you don't do these things properly, inspectors will be very quickly able to tell actually that staff are unsure what to do in practice. Documentation is all over the place. Records don't reflect reality. What you say in your policies is not what people are doing, because actually they can talk to service users to say, oh, do you feel that your medicines are handled safely? Some of them are very switched on. They'll tell you straight away that I'm a bit worried because I'm always having to remind them about this, or I'm having to do. And you see these inspection reports, you think, wow, there's so much here. But actually, it's good. Now we know what are we doing about it.
Yeah,
use
it's better
it
to know the problem rather than it be under the carpet. Yeah.
And also tolerance of risk. When it comes to medicines, actually, we should have a very low tolerance. Like even medicines courses, we had an outcry when we made our medicines courses 100% pass rate, and organizations were not happy. They wanted 80% pass rate. So I remember it was anaphylaxis and resuscitation, medication management. There was a huge outcry. And some people left us to go to other companies for e-learning because they wanted 80% pass rate. And I remember saying to someone, so are you saying to me that you want them to get it right 8 out of 10 times? If they can't do drug calculations, you're saying it's okay for them to fail 20% of the time. That's basically what you're telling me. So again, the tolerance is really important. If you address all these issues, actually, then you're not waiting for inspections to understand what's going on in your organization. It means that you're better prepared, and you realize also from an inspection perspective that medicines failures are directly linked with governance failures. It's as simple as that, which is leadership.
Yeah. So, like you say, the issue isn't just the error; it's that lack of awareness and control. And if leaders don't have that, then these problems can be sitting there, and particularly when outsiders, inspectors come in, they're more likely to find it. They're more likely to find some of those issues, and I think that, particularly when you talk about audits and so on, I think they're the bits that, even with some of my experiences speaking to people at the moment, you reading between the lines, you almost feel like there's no chance this organisation have done an audit recently, or there's no chance they've found time to do it recently, whatever excuse you want to give them. And we see patterns even with the services we offer. It's like, for example, some of the different things we offer where people are subscribing to a bit of software that we're doing. You can see how often people are, say, logging in.
Yes,
That is
log in
a classic
three weeks
KPI.
before renewal.
Yeah, you see when they log in, you see how often people refer to policy or refer to procedures, or you see how many people have even read the policy, because our system allows you to look at the read report. And then, like I say, if you then map it over to the training side, we have trainers that are using our training management system. You sort of think, this person's due for a refresher.
Yeah.
Where's the refresher? They're actually out of date now. You're sending
Although they've had reminders.
Although they've had the reminders.
Because we built a system to do that. But again, it shows you again to sort of say, look, what is the intention of having these systems? Because that's one of the biggest challenges now, where you have a lot of these tools. And
we did a session on this last year.
Last year we talked about this to say, look, a lot of these systems actually are causing more harm than good. I would rather have an organization that is using traditional pen and paper and doing things right, rather than digitizing for the sake of it. Then what tends to happen with digitization is that one or two people have logins, nobody else has logins. So that system is not serving much. It's not actually reaching the potential that it was designed. Because if somebody is logging in 2 weeks before renewal, and you can check actually, say, hang on, they haven't logged in, they haven't even got their staff to sign off the policies and procedures, they haven't done it.
Yeah.
So if you're not making time for governance, there's absolutely no hope.
You've got no chance
of
really,
that organization getting a good rating.
No.
So you're either going to be inadequate or needing improvement. It's as simple as that. And even missed doses. God, imagine, I remember Sir Liam Donaldson, he was the Chief Medical Officer for England. He's one of the biggest names in patient safety. You'd always use these examples, real life examples actually, of maybe patients that were harmed as his starting point. He had this idea, this skill really to bring it to life, right? Not necessarily just to shock people, but actually to get people to pay attention to the importance of patient safety. And you'd use Boeing, for example, to say, look, if there's a yellow cable that is found loose in a Boeing engine, it's going to make national news.
Yes.
It's going to be talked about on TV. Say, this Boeing was grounded. So all the Boeings of this make are going to be, particular model are going to be grounded because they found this problem, right? They're recalling them so that they can check all of them.
Yeah.
That's a near miss. The Boeing did not crash in the mountains somewhere. It was found to have a problem. And then they stopped all of them until they figured out how this problem happened. And then they rectified it. Then you'd say, if a near miss happens in a theater, in a hospital, you don't even make it past the corridor. And sort of think, actually, he's right. Many near misses are not reported at all. Missed doses are not reported. Because if there's a missed dose, if I'm a registered manager or a clinical manager, there's a missed dose, I would want to know about it. I would want to know about missed doses. What is causing missed doses? Like I remember when I worked in the front line, you'd put a 3 for a missed dose. Maybe somebody's gone for an X-ray or they're going to theatre, but you'd have to explain why. And also in the handover, one of my managers that I worked with actually was very fussy. You'd want you to put it in the handover, say, they didn't have this tablet in the morning because they went for theatre, but they drew the second one at 2 p.m. or whatever the case. Everything has to be documented. If it's not documented, it hasn't happened.
It didn't happen.
And if you ignore a near miss, it means that you don't care about what's happening in the organization.
That's the connotation, isn't it?
That's the connotation.
Yeah.
As simple as that. Yeah. Because if I miss a dose that has been prescribed, it shows me that no one notices, no one learns.
Yeah. So I've got away with it. So yeah.
Exactly.
Yeah.
And it tells inspectors also that organizations don't have effective oversight. right? If they're not dealing with these issues, there are no assurance systems in place. And also, if that's exposed actually through medicines, you're going to start to think, hang on, what else is unsafe in
Yes.
this organization? It opens a whole can of worms
Yeah.
that actually then leads organizations into special measures without actually digging that deep. It's just exposes.
It's almost the catalyst, isn't it? Yeah.
Exactly.
So, like you say, it's no real surprise, really. Particularly the more we talk about this today, that medicines feature so heavily in inadequate ratings.
And needing improvement as well.
Yeah.
The bulk of the organizations actually need improvement.
Yeah.
Well, I think good is the largest group, then needing improvement.
Needing improvement.
Then outstanding, then inadequate.
Yeah.
But again, you're not far from inadequate if you're needing improvement.
Yeah, exactly.
That's how I look at it.
Particularly in this area.
Yeah.
As well, with the types of regulations that it affects. So moving on now to some of the regulations, particularly Regulation 12 to 17. Let's talk about escalation. So once Regulation 12 starts to fail, what typically follows in an inspection?
17, Regulation 17, good governance, like we said about leadership. And you can actually see how the governance structure is working or not working. The moment you go into Regulation 17, like I said in the previous conversation, you start to see many other things that are also failing. And if you look into the issues that are arising as an inspector, they're not just looking at what went wrong. They're actually saying, look, how has the organization responded? So quite often, the organization has not responded at all.
Yes.
Or they have not responded appropriately. They've not done full sort of root cause analysis or even risk assessments, basic risk assessments to say, look, why did this happen? Can this happen in the future? Because that's part of your risk assessment process to say, look, somebody didn't get harmed this time, but actually in the future, someone might be harmed.
Someone might be harmed.
So if there's a chance that someone might be harmed in the future, then you've got an obligation to do something as an organization, as a leader. Otherwise, if it happens next time, and again, then our tolerance for risk, it rises and rises until it becomes part of the culture. This is how we do things here.
This is how we do things here.
And then staff very quickly realize that even if you fill in an accident report, nothing happens.
Nothing happened, nothing changes.
Even if you miss a dose, no one is going to ask you. And that becomes part of the culture.
Yeah. So Regulation 17 failures tend to sit just beneath the surface then.
Oh, yeah, certainly. Always. Because if you look at the 5 key questions, are you safe?
Yes.
So if you're not safe, then you're poorly led.
Yeah.
So you're inadequate.
Bottom line, yeah.
That's it. Never mind actually that your staff are caring. And it's quite painful. A lot of organizations that are inadequate and needing improvements, you see some comments from inspectors, staff were caring. They are very complimentary actually to the staff. And even the service users also will say good things about the staff. But actually, they are not safe.
They're not safe.
They're poorly led. So you do feel for the staff. We talked about audits to say, look, if your audits are not picking up missed doses, and I find missed doses, then they're not fit for purpose.
Even the audits themselves are not fit for purpose.
Yeah. And incidents that are recorded, but they're not properly investigated, poor leadership, poor governance.
Yeah.
Yeah, you're not going to be passing your inspection.
Yeah.
And the same errors happening repeatedly, nothing is happening, no evidence of learning, poor governance.
Poor governance again. Yeah.
And action plans that look good on paper, but they're not embedded into practice. You don't see a change in practice. Yeah, you just done a cosmetic paperwork and made it look good. Maybe used even ChatGPT to make it look good. Yeah. But actually in practice,
doesn't mean anything.
Nothing has changed.
Yeah.
So look, control, oversight from a leadership perspective, actually, you need to be able to explain actually the risks that are identified. You need to be able to tell us actually how you have rectified problems, how you are monitoring actually the improvements of the changes you have made, and also how you are reducing things over time. That's part of it, actually. That's part of audits and monitoring, is to have real data based on what's happening in organizations. In your organization, whether you have 5 service users or you have 10,000, like some of the large NHS trusts that are having 10,000 visits per month. Every visit matters.
Yeah, Every visit matters.
Yeah.
And I suppose that's where the real problem from a regulatory point of view comes in, isn't it? So, like you say, maybe talk us through as we move on in this section now. So, from, say, the CQC perspective, how is that looking from a regulation standpoint?
So Regulation 17 is governance and assurance, really. And it's about ensuring that leaders know what's happening in their services that they're providing. They can evidence safety, that safety is there and is actively managed. It's part of the culture. Medicines management is unsafe, then it means that governance systems haven't picked that.
Yes.
Right, if you're waiting for the inspector to see that, means you haven't picked that. So you can conclude reasonably as an inspector that the systems are not effective. And even if there's no immediate or serious harm, it's going to happen at some point. Because from a CQC perspective, we're not looking at what has already occurred. We're using that to get an impression of what might happen in the future as well. What is the risk of real harm to people in the future? And that's where, again, you then look at other breaches as well, from Regulation 12 to Regulation 17 to Regulations 13. It triggers them to think broadly, to sort of say, look, what else could be happening?
What else could be happening?
Yeah.
Yeah. So even when there's no immediate serious harm, the governance failure does really stand out, doesn't it?
It does. And like I said, actually, you move to then Regulation 13. We talked briefly about safeguarding earlier, safeguarding people from abuse and improper treatment.
Yeah.
Right? When people are repeatedly put at risk, when people are missing doses, when there's unsafe PRN use or over-medication, under-medication, inconsistent support regarding medicines, also, inspectors can reasonably assume that there's organizational neglect, and rather than one isolated or two isolated areas. Yeah. And quite often they are right. They don't even need to dig deep, actually, to see that the organization is not doing enough to fulfill its duty of care, even though staff may be trying their best. And sometimes staff also are not questioning what's happening
around them. Yeah,
because you can whistleblow if you have concerns.
Yeah,
as a member of staff. So if they're not doing that, then they could be found wanting as well. And if they're a nurse or a doctor, they may even end up being referred to their regulatory body.
Yeah, makes sense. So I suppose that's where medicine management becomes more than just a clinical issue.
Definitely. As we've said earlier, actually, it links with safeguarding, it links with staffing, it links with many things, because if people are not receiving essential medicines, if medicines are given without proper justification, medicines are used to manage behavior rather than actually clinical need, then that becomes actually a duty of care issue on part of the organization and also on the part of staff themselves.
Yeah, excellent. And that's where things can escalate really quickly. So yeah, maybe you can expand on that a little bit more in terms of Regulation 12.
Yeah, it cascades because things don't stay contained in just one regulation. These regulations actually are designed to work together as counterbalances.
Yeah.
And that's the problem. Actually, sometimes people are obsessed. I remember, care home group, well respected actually. One of the directors is saying to me, "Oh, so what do CQC care about this year?" And I said, "What do you mean?" He says, "Oh, every year we went for training, and the person was saying to me, this year they are caring about patient-centered care." I said, "They care about everything."
I was about to say, they don't just pick.
I was baffled, actually. And this person has clinical background. I was thinking, why would you think that they would care about one or two things? Says, "Oh, yeah, they're making a fuss about this." And so, if they see a huge incident, obviously they'll talk about
They'll
it.
highlight
They're
it.
going to highlight it. But actually, they're not going to focus on one or two regulations. They're looking... Then there wouldn't be they wouldn't fit for purpose as a regulator.
Exactly.
if they
You'd
did
start
that.
questioning their capabilities then.
Yeah, so regulations are connected. And that's why we, even in our podcasts last year and our webinars, we made a lot of effort to connect these things and bring training in as well. So look, when you're doing statutory and mandatory training, link it with the regulations. When you're doing your meetings with staff, get in the habit of mentioning the regulations and using the language that is expected in your sector so that your staff also can feel confident.
Yeah. So, like I say, I suppose for leaders listening, the key message is that the regulations, they don't operate in silos.
No, they don't. It's a fallacy, and the companies are making money telling these so-called consultants and some of these expert trainers who are lying to people. You need to look at the whole regulatory framework.
Yeah.
And like I say, medicines management is just one issue. We spend nearly an hour talking about it. We can spend a whole day talking about it. But also so is safeguarding. So is states management. So is staffing and training. All those things matter in their own way. Everything is interconnected, and leaders must demonstrate that safe medicines, safe management of medicines, and also effective governance, safeguarding assurances. If you don't have those, actually, then how are you going to keep your organization safe? And if your organization is not safe, then you're failed in your really basic regulatory requirement. You're failed.
Yeah. And it explains why medicines issues are so often feature in some of the enforcement action we see.
Definitely. It's a very quick way to test what's happening in the organization.
Yeah, excellent. So moving on to sort of training and competence and this false assurance side of things, a phrase we hear a lot, especially during inspections, is all staff are trained. Why doesn't that reassure inspectors?
Training attendants, you know this because your job really is to deal with companies, isn't it, on the front
Yes.
line and helping them set up.
Yeah.
Training is not the same as competence.
No.
It's a tick
touched
box
on it earlier,
sometimes
yeah.
actually. And statutory and mandatory training, they may be up to date, but actually, are they being implemented in practice? Are they actually people are signed off for competencies? Induction checklists may look complete, but actually, have people understood? If you onboarded them to the role correctly, yeah, it looks compliant on paper, but actually, it's not.
Yeah. So what sort of gaps are they seeing?
A lot of it is about visibility to sort of say, look, as leaders, actually, are you observing medicine practice? Even if you're non-clinical as a leader, you need to understand the systems, safe systems that you've put in place. So no formal sign-off for competencies, although they may have a certificate to say they attended the training. There's no reassessment over time. So they've done the training. There's no renewal of that training. There's no element of refresher at any point, not even in supervision, not even in staff meetings, and little or no supervision on medicine safety. That's considering how important it is as an issue, actually, it needs to be part of the supervision for everyone who has responsibilities for administration and handling medicines. And no clear understanding of who actually is competent to administer medicines. Because if I've got 20 care workers, 3 of them may be competent for a particular medicine or particular conditions, but not everyone.
But not everyone, yeah.
And then if I don't train those people, cascade that training and sign them off for competencies, yeah, they may go with someone who's competent. Doesn't make them competent automatically. It's not osmosis,
Yeah. So, like you say, the assurance is assumed rather than proven.
Oh yeah, definitely. And it's false assurance when you think about it. Actually, dashboards are showing 100% completion, but actually in practice, you're barely, doing even 50%.
Yeah, and certificates obviously don't answer that, as we've touched on earlier on as well.
Can you prove that people are safe to administer medicines right now?
Yeah,
right.
That's
and
the key
if there are
question,
failings, can you prove that you have done enough for them to safely administer medicines in the future? Quite often that is the missing link.
Yeah.
Yeah.
Excellent. So, like you say, that's the gap that seems to come up a lot in inspections reports, isn't it? Like you say, training, tick, policy behind the desk or on a new fancy software application, tick. But then it only takes an inspector to come in and do their statutory sort of checks and
Yeah, because look, they did a training at some point in time, and even when inspectors come in, they're looking at this organization where it is right now.
Yes,
right?
a point in time.
It's not inspections are not perfect, but they're very good actually. If they're done properly, they're very good at giving you a picture of what's really going on
and a
in
health
the
check on
organization.
the business as
Exactly.
well.
It's like taking your car to an MOT. It may break down just immediately after you leave. It doesn't guarantee. And I think that's the self-assurance, the false assurance that people get sometimes. So, how well did they understand the training, actually? If they localized actually into their practice as well, can they apply it in practice? Also, are they competent 6 or 12 months later? If they're not doing refresher training, if it's not in supervision, how do they maintain their competencies? How do they respond when something goes wrong? So again, psychological safety, where we're not blaming people. They can come forward actually under the duty of candor, statutory duty of candor, actually, to be open and honest, and then step forward to say that they got it wrong. So look, inspectors are looking for assurance of practice, right? Not assurance of attendance. It's easy to show that somebody went for training, but actually, how are they applying it?
Yeah. So what's missing at a systems level then?
So look, the pressures on staffing right now, even winter pressure, it's real. We are seeing that when we talk to organizations, whether it's an NHS trust or further down the stream, staffing is tight, turnover is high. Sometimes agency staff are used disproportionately, so the organization is failing to retain staff. So often we are delegating medicines-related tasks on the assumptions that training equals competencies. And if somebody was trained somewhere else, but they've not used our systems, we give them a good induction? If we're repeatedly using agency staff or temporary staff, then it's going to be very costly to keep inducting people. Then they end up just going to work straight away without adequate know-how of how your systems work. So without observed practice and reassessment, the assumption is unsafe. There are a lot of assumptions that are made, and these assumptions are unsafe.
Yeah. And like you say, trust isn't enough in a regulated environment,
yes.
Particularly with the topic we're dealing with here.
Exactly.
Yeah. So the message to leaders is that training is necessary, but not sufficient.
Oh, yeah, definitely. There are so many things that we need to think about, who's authorized to administer medicines, under what circumstances, and whether their competence has been assessed. When was it last assessed? When is it due again? When you get new medicines in, what are you doing to improve the systems and make sure that people are up to speed? What happens when concerns are identified? So, it's easy to sound like a broken record, but those are the realities actually in practice.
Excellent. So I just want to take the conversation towards now, not just talk about risk, but something called normalized risk. So I suppose one of the most worrying themes that does come up, and even from some of the work I do with clients, this does come up quite a bit, is how unsafe practice slowly becomes normalized.
It does. And I think a lot of the things we've discussed so far are red flags that lead to normalization of unsafe practices.
Yeah.
Then it becomes an organizational culture where safety is
it's embedded.
Yeah, so safety is not fully embedded, and unsafe practice becomes embedded instead. So the opposite of what we're intending to do. Yeah, and normalized risk is one of the clearest indicators actually that an organization is drifted away from safe practice, right? Because they don't even see what's in front of them.
Yeah.
Right. And missed doses are shrugged off as one of those things, or if they refuse medications, and then we just keep saying, oh, they refuse. Nobody is making an effort to actually address why they're refusing medications. That becomes normalized. So the stock discrepancies, they're missing medicines or whatever, then you just treat it as routine, just order some more, and if the pharmacy is not asking questions, the GP is not asking questions, the prescriber is not asking questions, then it just becomes normal.
Just becomes normalized, yeah.
What we do every day consistently becomes the norm. It's as simple as that.
And obviously, those things shouldn't be routine.
It shouldn't be routine,
Goes without saying, yeah.
It goes again with professional curiosity. You don't have to be a nurse or a doctor. Even care workers actually have natural curiosity to ask questions, to challenge, take action. Remember also whistleblowing. I know sometimes people still fear that if they whistleblow, they may still be penalized for it. And there have been some instances where people have been penalized for whistleblowing, but actually then if you don't, you're complicit with what's happening. You're part of the problem. And we've seen that even when Panorama does these programs where they go into organization, no one has asked why this is happening. No one has considered actually that people are being put at risk. No one has considered actually the wider issues. No one has considered actually what needs to change. It becomes part of the problem.
Yeah. And that's when leaders lose sight of what's really happening, to be honest, isn't it?
Exactly, because they're on autopilot. Yes, there may be problems with staffing. There may be problems with funding. You're trying to fill up the beds and all that. But don't forget the business that you're in.
Yeah.
People using the services, the ones that you have right now, their loved ones, so quite often they are more aware of medicine risks than managers. We have had colleagues who come to us actually to ask us questions. To say, oh, my mom is in a care home. what do you think about this? And you think, oh, that is really scary, right?
Yeah,
But
yeah.
but what they're trying to do is to raise a concern. They're not trying to report the care home. They're just concerned to say, look,
This doesn't sound right. Yeah.
doesn't sound right. What do you
Yeah.
think about it?
Quite
So
often, yeah.
that's really important, and it's not just for managers and business owners or so-called leaders. Everybody can lead. You can self-lead. So I keep emphasizing that curiosity, professional curiosity, to say, look, where you are, you can make decisions. Where you are, you can improve care. Where you are, you can actually help to turn things around as well. Everyone has authority to do that, where they are working. Because if you sign a contract today, you're going to do the job. If you're the nurse giving the medicines, you actually have authority to make things happen or not.
Yeah. Yeah. So, like you say, the information's there. It's just not reaching the right level, ultimately.
Yeah, definitely. Definitely.
So, just moving on a little bit now then. So, from CQC's point of view, the question is never just what went wrong. There's a deeper context behind, like you say, what they're trying to assess when inspecting. It's not just a black and white question like that.
It goes deeper. Of course, something goes wrong, but actually things do go wrong in the healthcare sector, in the care sector,
Of
all
course
the
they do,
time.
yeah,
You're
yeah,
dealing
yeah.
with human beings, and people's condition can change.
Yeah.
You're going into emergency mode. So, but otherwise, who noticed actually when things went wrong, right? What did they do about it? Was it escalated? And who acted on it? Was there dissemination of what we learned? Did we learn something actually and actually document to say we learned this? Did we disseminate then to people to say, look, that is what good leadership is about. We may get it wrong, but now that we found out, this is what we've done about it. This is what we'll do in the future to ensure that this problem doesn't keep coming back.
Doesn't keep coming back, yeah. And like you say, by that point, it can be too late as well, yeah.
Definitely, because if systems are not working or loops for feedbacks are broken and assurance is assumed rather than tested, then your indicators actually are losing them fast.
Yeah. Excellent. So I just want to move on now to what good looks like in medicines management, because we're coming towards the closing part of the episode. So if we now shift to solutions, we've talked a lot about where things go wrong. So what does good medicines management actually look like?
It's really about systems, governance systems, so control, visibility, and learning. So clear accountability at every level. Everyone needs to know what they're supposed to be doing.
Yep.
Everybody needs to know the checks and balances. Everybody needs to know about the guardrails. So what does good look like? You document it. You train people. You give them induction. You audit those systems to make sure that they're working. You monitor those systems. And you give people feedback. You involve people, including the service users as well. Everybody needs to know what they're supposed to be doing.
Yeah. So like you say, there's no grey areas about ownership, about the process, about the policy. It's got to be transparent.
A little bit of ambiguity, actually, that's when you start having problems. When people are not sure what to do, then you have all sorts of problems. So the second thing is to move beyond training attendance. So you're actually saying, look, competence-based assessments, assurance, observe practice, signing people off formally as part of their supervision, and regular reassessment, and include medicine safety and risk management in general, broader risk management in supervision. Competence that way isn't assumed, it's actually evidenced. We're talking about it as we go. Yeah.
Excellent. And like you said, it's a big shift in mindset for some services, but that's the reality if you want to reach the top level of being outstanding. Yeah.
It is, because audits should genuinely address identified risks, not tick box exercises. You're reflecting what's happening in practice and highlighting themes and patterns, triggering action, and also reviewed by the right people.
Yeah.
Don't make sure that the people that are reviewing these audits actually are competent to do
And know what they're doing.
Sometimes you may need outsiders. Actually, there are some very capable people out there who come in and do maybe a quarterly review or an annual review, and then let them have access to the systems, and then they'll be able to advise you accordingly.
Yeah. Excellent. So, like you say, audits then become a learning tool, not just a compliance tool, or like you say, a blame culture tool either.
Exactly. It takes us to real-time oversight as well. If you have these, because you can't know everything that is happening at any one time.
No.
But actually, if you do then regular audits, you're not waiting for an inspection or that annual audit that you do. Do them. Have targets to sort of say, look, we'll do one every month or one every 3 months.
But
But actually,
unannounced
yeah,
as well.
exactly,
Yeah.
unannounced. But also have data feeding in about other things happening in. That's part of auditing as well. Having systems actually where they provide you a glance as to what's happening in the organization. You pick things early rather than retrospectively, and you then be able to deal with them before they become real problems.
Yeah. And like you say, that then ties into the governance at a higher level as well.
Yes, it needs to go to the board really. And like we're saying with the large NHS trusts and big care groups, there'll be somebody there, maybe director of nursing or chief nurse, there'll be medical director, there's somebody responsible for governance. But for smaller organizations, you need named people to do these things. And, you need to understand the key risks related to medicines, how they're being managed, the assurance needs to be strong, and also the improvements that is still needed and how you're going to achieve it.
Again, to achieve it. Yeah. So, like you say, medicines management then becomes part of the overall risk conversation.
Yes, it's a joined up system. It's a part of the joined up system rather than looking at it as a silo. That fragmentation actually then moves things out of sight. And then you're dealing with them as if they're special cases, but actually they're related to everything else.
They're all related, yeah. And like you say, when we talk about integrated compliance and governance systems, that's where, in this example, it really comes into play.
Oh yeah, definitely. And when the way I look at it actually is you're connecting everything from training to policies and procedures, from competencies, sign off, audits, incident management, supervision, even your reports as well. Even if you're not required to do a quality report, learn how to do a quality report. Every healthcare organization or care organization should do a quality report, whether it's a statutory requirement or not. NHS trusts have to do it. Of course, they're better funded, but actually even smaller organizations should have systems for quality reports as well for themselves. And also, it will look good for commissioners as well and CQC inspectors when they come and see that you are actually taking things that seriously, even if it's not a statutory requirement.
Even if it's not, it shows a willingness, doesn't it?
Yeah.
And it shows good leadership. So, look, like I say, I think that's a strong note to sort of move towards a close. But what I'd like to do just before we close today's episode is look at maybe if you could summarize some practical steps organizations can take based on medicines management and what we've discussed today.
So 5 things. The first one is, when you look at safeguarding, for example, we say safeguarding is everyone's responsibility. I'll say the same actually. The first thing is medicines management is everyone's responsibility. Everyone in the organization, right? It's really a governance priority. We need to make sure that medicine safety is visible at senior and board level and not buried in operational detail or to the clinical team alone, right? The second thing is moving from training to competence assurance. Most people working in health and social care, it's like apprenticeship really, isn't it? You're coming in, yes, you may have done training somewhere or you've got a nursing degree or a medical degree, but you're now going to learn working with others. You need good systems to support you to do that. So competencies are important to sign people off. Then strengthen documentation as a safety control. Documentation is crucial at every stage. My charts, audits, records, they must be accurate, they must be timely and actively reviewed. Remember GDPR requirements as well, data protection requirements. And then number 4, identify and act on risk early. So our risk management systems, hazard assessments, risk management, and even when we do investigations, not to blame people, even if you're doing a root cause analysis, you're doing it to learn what's actually happening in the organization, using the audits, the incident and accident reporting systems, escalation pathways. Genuinely, are they working in practice or they're just there to tick boxes? Then finally, join systems together. Like we said, there's so many regulations that are interconnected. Medicines management must connect training, supervision, audits, incident learning, governance. If you have any fragmentation at any point, it creates and hides risks. Any ambiguity, it hides risks. It goes underground. And then you're waiting for problems to happen, or you're waiting for that day when the inspectors come in to tell you exactly what's happening in the organization in front of your own eyes, but you have no systems to see it.
To see it, yeah.
Yeah.
Excellent. Well, like I say, that's a strong and practical note, I think, to end on. And hopefully everyone will learn something from this, but also, more importantly, have some ideas and solutions to take back to their organisation, whatever level you are working in that organisation. Like we say, it's everyone's responsibility. So thank you, Richard, for today. It's a very insightful conversation and a crucial conversation to have. And we'll be back next month, not next week, but next month on ComplyPlus Presents in our new studio as well, which is quite exciting. So we will be with you again next week discussing some more vital topics. Thank you.
Fantastic. Stay safe, and remember, leadership, governance, that's where it fails.
Yeah. If you remember those two things, you should go a long way.
Thank you very much.
Thank you.